We've been talking about moving care into the home for years, and yet hospitals are still overflowing. ERs are still the default for seniors, and the system hasn't actually shifted. Meanwhile, hundreds of hospitals in rural areas are closing due to political and funding changes, which pushes even more volume onto suburban and urban hospitals that are already at capacity. And when patients do get discharged, rehab beds and long-term care facilities are disappearing too. We've lost thousands of long-term care beds in the last 5 years alone. So we keep saying hospital at home is the future, but the present is a system that's shrinking on every end while demand is only going up. My hot take this week, at some point, we have to stop calling it a transition and just start asking why it hasn't happened yet. This week, we're asking questions about why this isn't a reality yet and what it will take to get us there. What does higher acuity care at home actually look like, and how is it different from what most people picture when they hear hospital at home? If we can treat conditions like CHF exacerbations and infections at home for a fraction of the cost, why is the ER still the default? What role do caregivers play in home-based acute care models? And how does keeping someone home change the burden on families? And why is the healthcare system so slow to move toward value-based care when the financial and the patient outcomes are already pointing in that direction? What does it actually take for insurance to cover in-home acute care? And where are the biggest gaps right now? To help me break this down, I'm joined by Lon Hecht. With more than 25 years in healthcare, Lon is a passionate advocate for reimagining how and where people receive care. Welcome to the Aging Together podcast. I'm your host, Dr. Pooja Ashok Patel, a double board certified occupational therapist and gerontologist with additional certifications in dementia and fall prevention. This season, we are unfiltered. In this podcast, I interview guests who are experts in their fields or caregivers who are sharing their lived experiences. Let's meet today's guest. As CEO of Care2U, he leads a mission-driven organization bringing emergency room level and hospital grade acute care directly into patients' homes so families never have to choose between quality care and the comfort and dignity of home. Lon has spent his career at the intersection of patients, providers, and payers with a deep belief that the best care meets people where they are. His work in value-based care focuses on building models that put the patient experience first, a philosophy that resonates with the millions of family members caring for aging loved ones every day. Before founding Care2U, Lon served as an SVP of growth at Optum Home and Community Care, where he led the strategy and expansion of the full population management solution, giving him a ground-level understanding of the challenges seniors and caregivers face when navigating complex health needs at home. Lon is deeply committed to helping seniors live fuller, more connected lives and to support the caregivers who make that possible. He understands that caring for an aging loved one is one of the most meaningful and demanding roles a person can take on. Lon, welcome to the show.
Thank you so much. I feel like my work here is done just with your introduction. And by the way, I'm taking care of a senior right now, my mother, and it is quite a challenge, so I can definitely relate.
Yeah, I think we'll have so much to talk about. You've got such a boots-on-the-ground experience with this work, and now you're living it as well. Before we go into all those details, though, I can guarantee you have a hot take in this industry, so give me your hot take.
Well, there are a lot of hot takes in the industry. I'll give you one on point with what we're talking about today, and I think knowledge is power here, and I think that people need to understand that you can get this high acuity care in the home, that you do not have to go to the ER for everything that's more complicated than your traditional primary care or specialty visit. It does not have to be the easy and automatic button, because having someone come to your home pretty quickly could do that at a fraction of the cost and also give you the care that you really want in a really safe environment where you're not subjected to other infections and things of that nature. I think the hot take is knowledge is power. Like, you don't have to go to the ER for everything. The ER is for a lot of things. Don't get me wrong. You're having a stroke or a heart attack, but so many of these things you just mentioned in the intro can be handled very easily at home.
Mm-hmm. Yeah, one of the, I don't want to say pain points, because it's really not a pain point. People just don't know better of where they should go. But there's, in my experience working in acute care in the hospital for a decade, I primarily have worked with the older adult population in the hospital as well. And one of the most frequent reasons they come in is for acute infections, right? Whether that's a UTI, pneumonia, any sort of upper respiratory infection, or a fall. And these are things that, I think if people knew better, that could be addressed in an urgent care, and they can direct people to an ER if they really need to go, right? But that's considering, or that's if they have access to an urgent care nearby. Sometimes the ER is closer.
Right, true. And I'll tell you, we triage when we get calls, right? So we get the call in from the patient, caregiver, doctor, care manager, it could be anyone. And we're going to understand what those symptoms are. And sometimes they need a lower level of care, and we're going to let them know. And we have access to know what are in-network urgent cares that they can go to in their area to try and keep them in their network and get them somewhere else where it's more appropriate. Sometimes they need to go to the ER, and we're going to escalate them over there as well. Funny you mentioned urgent care. I just had a call yesterday with leadership at a very large urgent care chain, and they have a challenge. When somebody comes in and they have a UTI, they escalate them to the hospital. And it's not necessary. It's interesting, right? Because it all depends if they need some initial IV antibiotics or something like that. They may be able to give that first dose in the urgent care, but they're not going to be able to give continuing doses for multiple days. So I'm sure the health plan would prefer them to be sent home to us, where we can do it at a fraction of the cost, rather than go to the ER, cost the patient a lot of money, cost the insurance company, the whole system a lot of money, and it's just safer to be at home. So we're trying to figure out where all these different entry points we can hit and have those really intelligent conversations about it. And that's going to make the urgent care's value proposition a whole lot better when they talk to a health plan, because the health plans will look at urgent care and say, okay, well, originally you were supposed to be urgent care, but now you're seeing some primary care related things, and where does that go? And now you're escalating a lot to the ER. Well, if that urgent care is now saying, yeah, but we know that they could have gone to the ER, but we're going to actually funnel them back home where it's safer, that's a value proposition to the health plan. Now maybe they're in a position to be able to negotiate better rates, because I don't think urgent cares are getting better rates over the last 5 or 10 years, right? So everybody's got to be really mindful of this value equation.
Yeah, I think you brought up a really good point about, I think, value proposition, which of course I don't know that our audience necessarily knows what that means, but for the healthcare professionals who are listening, I think it's really important to understand that, because that's sort of the same concept that I've tried to describe when we talk about preventative or proactive care in primary care versus the reactive system that we generally tend to work in, especially as rehab therapists. And so I think let's start with a basic of, I feel like we've just talked about multiple levels of care. Can you explain maybe the similarities or the differences between acute care, urgent care, this emergency care at home that you're talking about, and just to kind of give a layperson some insight into what we're talking about here?
Sure. And before I do that, I'll say what I think I called it value proposition, or value, whatever that value driver is, just for your audience. It's whatever is important to that particular party. So what's important to you as a patient? I want to get really good quality care. I want to get it at a reasonable price. I want to get it timely. And I want to get it potentially in a place where I don't have to be subjected to other infections, things of that nature, right? So that's my value proposition. A health plan's value proposition is, I want to be able to treat patients well, but I want them in the appropriate care setting at the appropriate cost. I don't want to spend all the money for them to be in the ER when it's something they could have gone to their primary care doctor to, or an urgent care. So everything, and so it's all how everybody really looks at that. So for your audience, I think the way I would look at the world is, when I'm sick or when I'm not sick, I have multiple levels of care I can go to, right? So one is my primary care doc, and that is your annual wellness visit for your checkup, or I have some kind of infection or strep throat or whatever. It's one of those things you can go to. If your doctor can get you in same day, great. But if you don't go for a couple days, it's not the end of the world. Like, you're going to be okay. Urgent care to me is, it's kind of that next level, right? Like, I need to get care pretty quickly, and it would be a whole lot better if I got it today, or else that could lead to cascading events that cause more problems down the line. And urgent care is more expensive, right? Because it's an on-demand kind of care model. That next level is acute care or emergency care. That is something that's the next level higher, right? I would say maybe acute care is more of these things like congestive heart failure exacerbations, pneumonia, complicated UTIs, urinary tract infections. It could be a COPD exacerbation, which is just a flare-up. It could be things like that. These are things that, are very challenging, but can be handled in an appropriate care setting typically, as long as things aren't too bad, right? Emergency is emergency. I'm having a stroke. I'm having chest pains with a heart attack. I had a traumatic head injury. I'm on blood thinners, things like that. Those are you need to go to the ER for that. That's where you should be. And that's why when we get calls, we try to triage them. And I get it. It's not easy for people to always know where they go. And their primary care is a good place to start if they have plenty of time. But then as you go up, costs go up, some risks go up, different things like that you just want to be mindful of.
Yeah. I am just going to be so honest. I think
Please.
With primary care doctor's offices, at least in the Chicago area where I live, sometimes it's a 2-week wait before you can get in to see your primary care doctor in today's industry.
If you want to find one, it could be an 8-week or it could be months.
Yes, if you need a new doctor, yes,
Good
it can
luck.
definitely be, and it didn't used to be like this. You used to be able to walk into your doctor's office and get seen at one point, right? And then it shifted to, okay, please make an appointment so we can be prepared, and you were still able to get an appointment within the day or two. And then it moved into this situation now where oftentimes you want to be seen by your primary care doctor because you're not feeling well or something's off. They give you a 1 to 2 week wait. By that point, you're probably already feeling better if it's just minor, or you're going to urgent care or the hospital because your primary care doctor is not available. Right?
You're right.
And I don't know, do you have insight from your administrative work on how or why that happened?
Well, I do have a take on it, my opinion. So
yeah, go for it.
The world is really complicated, and I don't want to get too complicated in this for this conversation, but you, I know, are interested in value-based care, right? So there's the model that the world works on right now for doctors is something called fee-for-service. They get paid for everything they do. So what are they incentivized to do? As many things as they can do, right? And reimbursement has gone down over time. Doctors used to be incredibly highly paid. Now they're not as highly paid as your audience probably thinks, especially primary care and other areas. So they have to see a lot of people. They have to see literally a patient. It's something like every 6 or 7 minutes to be able to financially do well. It's crazy. I may be off on that. So, hit your AI agent and see which one tells, what the truth is. But they have to see a lot of patients. It could be 6, 8, 10 patients an hour. So they have to have those full schedules, right? And that's the really big challenge for it. So now it's all about how many people I can get through. It becomes all productivity. The world wants to get to a value-based care model, right? Which isn't where we pay you, doctor, for everything you do. It's we give you a patient panel and keep them healthy. And if they're healthy and you keep costs down and you keep them preventative, you make more money and you can make money. And that's where the world wants to go. And I'm a firm believer in getting there. The challenge is right now is we've had one model forever, right? And then you have these health insurance plans, which I was a part of Optum, which is owned by United. They want that value-based care. The problem is now doctors are kind of resting with their feet in two different boats. On one hand, they're used to doing as many things as they can possibly do. And now for maybe 10% of their patients, they're judged on keeping them healthier and doing less because you're spending more time with them. And it's just when is that going to ever give? Because it's really hard to serve two masters. And right now they're having to serve two masters. The way it speeds up is eventually payers are just going to say value-based care. And then eventually folks are going to have to figure it out. The problem is doctors aren't very good at this value-based care model yet because they're so trained to do as many services as they can. And I'm not knocking doctors at all. It's the model, and that's how it was built, and that's what people have to do. So it's really challenging for doctors. I don't envy the position that they're in, and doctors at their core want to do the best they can for their patients.
Yeah, no, I totally get that. I foresee, because those of us who can afford it, what we end up doing is we sign up for these concierge clinics, which is value-based care, but it's out of pocket. And that way I can text my doctor and be like, hey, I'm not feeling well. They're like, okay, cool. Can you come in the next hour or two? We have that ability when you have concierge medicine. Concierge medicine can operate as value-based care models, but they don't work in the same way, or they don't get paid in the same way from health insurance plans. And so then it becomes an out-of-pocket cost, right? You still need health insurance because if something happens outside of regular doctor's visits, you're going to need coverage. So now you're paying for two things at once, right?
Yeah, but we just came up with a new model right now, and that would be an insurer that comes up with a concierge model where you get a concierge buy-up with a concierge physician, but a lot of those things could go against your insurance costs. So it's a little more money, but on the back end, maybe there are some value-based payment mechanisms there. So that's a really cool, innovative way to think about things. Maybe somebody's working on that. I love that. I think that's cool.
Yeah. I think what I was earlier, I think I referenced some of the value-based care work that I had looked into. specifically related to primary care was the primary care first model that they rolled out the pilot program under the value-based care programs through CMS. And that was something I was like, okay, how do we get therapy in there, right? Like, how can we get therapy proactively involved in this model so that we can also offer preventative and proactive assessments and evaluations that could prevent a fall, prevent an infection, prevent cognitive decline, right? Like all of these things, or do early detection, because that leads to early intervention. The faster, earlier you pick up on something, the faster and earlier you can address it. And there's no easy way to do that.
Nope.
Because ultimately, the program only covers the physicians and maybe a nurse.
Right.
And so anything outside of that would be them losing money, or we still have to credential with insurance payers and bill fee for service. And so I think there's a lot of gaps when we talk about this transition to value-based care and this transition to almost this concierge kind of system. What you're doing is very different from that system, but you're really trying to decrease the amount of demands that are placed on an emergency room. Emergency room wait times range anywhere from hours to sometimes up to a day, depending on where you are, right? Depending on what hospital you're at. If you're at a major trauma center and the emergency room is filled to the brim, you could be in the emergency room all night, 12, 14 hours before you get a bed, right?
And then they'll put you in something called observation care where they bill you, and that's like $6,000. And then it hits, you're going to have an out-of-pocket component to that. It gets very expensive very quickly. And observation care usually means you're sitting in a hallway for 12 hours, right? It's pretty complicated. So
depending on the hospital, yes, very much.
Right. So it can be a mess. That's why we're really trying to change the model, which I haven't even explained the model. If you want me to, I can probably in 30 seconds or a minute. What we do is when we get a call from a patient or a doctor or a care manager or home health agency, whatever it may be, we deploy into the patient's home within 2 to 4 hours. Right now, our main market is New York, but we're planning to expand out into other markets very quickly. And my company, just so people can look it up if they want, is Care2U. So that's CARE2U.com. And so we send a physician assistant, nurse practitioner, or paramedic into the home. They're there within 2 to 4 hours. They work up the patient. They typically spend about 70 minutes with the patient, 70, versus what do you get, 5 minutes in an ER. They then bring another provider on. They bring a doctor on via telehealth. So now you have 2 providers. The doctor's probably on for about 15 minutes and they work up that care plan. And we can do things like imaging and oxygen concentrators and stat labs and point of care testing and suturing and, IV infusions, all kinds of stuff in the home. So we do that. And if we can treat you in that one visit, but we avoided an ER visit or a readmission, if it needs more care, we can admit you into our service right in the home. So I don't want to call it hospital at home because we're not a hospital, but it's hospital level care in the home. And then we can treat you for that episode. And ultimately, we're always transitioning you back to your doctor, to your primary care doctor, to your specialist, everyone else. We're just in there for that episode to help you out. Then we're transitioning you back to your main provider. So that's how we work. We do that. If you look at Medicare, we're about a third of the cost of what it would cost to go to the hospital. If you look at commercial insurance, which is what you and I would have at our ages, we're about a sixth of the cost. That's how expensive healthcare is. It's outrageous. So it has, there are a lot of wins in there for folks.
That's really interesting. So I'm trying to understand. So you mentioned that first call, that's like a one-time visit to figure out what's going on. But then if they still need continued care, then you enroll them into your in-home service. What does that look like?
Right. So what we'll do at that point is we look to make sure they meet the right criteria for hospital level care in the home. If they don't and they truly need to be in a hospital, we're going to arrange transportation to them to get them in. And we work with a lot of hospitals so we can kind of expedite that pathway into the hospital for them often. And then what we'll typically do is if we're admitting them to the service, we'll put them on something called remote patient monitoring so we can get all of their vital signs remotely as well. And then what we're doing is we're sending someone into the home 1 or 2 times per day for that episode, at least one in person. The second could be in person or it could be telehealth. It depends on what you need on your, based on your individual situation. And we're staying with you for that episode. As soon as we can transition you back to your primary care specialist, we're going to do that. The other thing I'll mention is once we are not needed, once we can transition you to a lower level of care, we're going to do that, right? So maybe there's a point at which you need us for the first day or 2 or 3, maybe 2 or 3 days, and then we can transition you to home health or to an infusion partner, which would be less expensive, we're going to do that. So we're always trying to be really mindful of cost for everyone. So we want to be in there when we should be in there, and then when we think it's appropriate to transition you, we're going to transition you out to the right provider.
There are pretty streamlined, like quantitative measures where you're like, okay, yes, no, as far as like admitting versus not admitting, yes. I imagine.
We have protocols. We have protocols for all of that. Yes, it's very streamlined, and the providers know exactly how to go through that checklist. We want to make sure the environment's appropriate for everything as well, and then we set them up. And as I mentioned, we'll set you up on remote patient monitoring, which is great because we can monitor you 24/7 and make sure there aren't any kind of status changes or anything like that. One thing I'll say is when we're doing that 24/7 hospital level care in the home, it's not what you picture in a hospital where you've got like beeps and boops everywhere and you're all plugged. You can move around your house if you feel up to it. You can do those things, and that's what's really cool. Because if you think about it, when you're in the hospital, you're stuck, right? But when you're at home, I feel like people heal better at home because you can, if you feel up to it, walk into the bathroom or walk into the kitchen. You can be with your pets and your family. It's nice. And the other thing is it's also nice for caregivers that, like if you think about New York, it's not convenient to go to a hospital in New York, right? Every time you go to the hospital, you're going to spend $60 for parking. It's going to be a nightmare to get there, all those kind of things. Having that at home is just a really nice difference for them. So, that's something that I think caregivers care quite a bit about.
Yeah, absolutely. We are going to talk about the impact on caregivers because that's definitely a big area of work that I do. But before we get into that, I wanted to kind of ask you, so my work in the hospital, we're seeing we have like what we call an ED for the elderly. So it's a geriatric unit, right? So it's a little more adapted, a little more environmentally friendly. And so for patients who end up going into those units, even if they're observation, so we have the observation units for them, they're still getting consults for therapy, for other doctors as needed, for social work to help with support. How does that translate when you're seeing them at the home for, let's say, a similar issue, right? Because let's say they came in with a fall and they just wanted to make sure nothing was wrong. They got placed in observation. So of course, PT comes in, does an assessment, OT goes in, does an assessment, social work goes in and sets them up with X, Y, and Z resources. Now, if you're going into their home just to make sure that they're not injured, they're not necessarily getting those consults for other rehab providers in the moment. Do you have a process for how that?
Yeah, we do the full wraparound care coordination for them. So when we go in there and we do that initial assessment, if they're going to need like PT, OT, anything like that, we're setting that up for them. We're getting the folks in there. If they need imaging, and we have some imaging with us, some we need to bring external folks in, so we'll set all of that up. Social determinants of health, we'll do assessments right there, connect them with social work and everything. So yes, we're doing all that. It's really important we do that wraparound work for them. And one thing that also is cool, if we're doing a hospital level episode on you, we're going to stay with you for granted, we may be in the home for 2, 3, 4 days, 5 days, whatever it may be, but we're going to stay with you for 30 days. So we're checking in and making sure there aren't any kind of other needs. We're connecting you to all the right specialists and all the right follow-up doctors and everything. So we really do a ton of care coordination on the member. And another big one I'll mention, which is, I just don't want to forget, I think is really important, is advanced care planning is something that people don't want to talk about until they have a need to talk about it. We talk about it a whole lot because people are having status changes in the home. So it's actually, I find it to be a much better place to have those conversations than you would typically have. So we do a lot of advanced care planning. We also do a lot of palliative and hospice consults and everything because it's a good time very often to have those conversations. We see people that are 18 and older eventually will get younger than 18. And we do see a ton of seniors, but we see people of all ages. But on the senior end of it, we're doing a whole lot to educate them on all the other levels of care that they might need. And we have the time to do it because it's not like in the hospital where you're running around and you've got a couple of minutes with one person. Like we're in there and we're doing the infusion or whatever that may be. And there's all this time for us to kind of be able to go through and do those things. So it's nice.
I love that you brought that up because that will open a whole can of worms on my end.
Yeah.
But that's the work that I do is proactive care planning with, education and then actually putting pen to paper as far as like what might your needs look like. Let's make a plan for rehab, for long-term care, for end of life. What's your plan for hospice or palliative care if you need it? Like we have all these conversations. People don't want to talk about it. And it becomes this like grueling process of being like, hey, you should really talk about this. You should really talk about this. And we don't really get that time to do that in the hospital, right? Unless someone is truly considering hospice or needs palliative care, then the palliative care team is going in or the hospice team is going in and they're having those conversations, right? And they have chaplains and social work and they have all of that services there, right? But I always argue that we should be having these conversations at home at like 40, at 30, at 50, right? And that was something that really opened my eyes during the pandemic because so many younger people were dying. You know, families didn't know what they wanted because we generally don't think about it until someone's older. And so my recommendation is always, you know, the minute your child or you turn 18, you should start having these conversations because they go off to college, something happens, you need to know.
Not to sound morbid, I have it for me, for my wife and my 2 kids who are 24 and 25.
Yeah.
We're all set.
Yeah, you have to, right? And yes, it's always morbid, but I talk about it so much that it's one of those things. And my listeners know it because I bring it up almost all the time of like, have to think about, it's the only sure thing in life is that you're going to die one day, right?
Well, I can think of one other since April 15th just passed, so.
Well, yeah, taxes.
Yeah.
Yeah. So that was a bit of a caveat because you did bring up advanced care planning. And I just think enough people don't think about it, don't talk about it. And I do appreciate that you have that embedded into the work that you do for every patient that you see. Does this hospital episode at home count in the same capacity as like a hospitalization? From like an insurance standpoint?
No, so patients will love this in most situations. So I've been able to go out and work with a lot of health insurance plans to get this covered by insurance plans and a lot of accountable care organizations and large provider groups that are in these risk arrangements, which is probably more than your listeners want to hear about. But I've gotten a lot of people that are willing to pay for it. And the way I've contracted for it is they pay a specialist copay for this. So when we go into the home and do an ED avoidance visit in the home, they're paying a specialist copay, which for most insurances is, let's say, $30, $35 versus an ER copay, which could be $100, $200, right? And then when they get hospitalized, they usually get a big copay, and then they get maybe a co-insurance. And for us, it's a specialist copay a day, typically. One insurer that I'm contracted with for an entire hospitalization, it's a $100 copay for the entire hospitalization in the home, right? So not only is there a value for the health plan, there's a big value for the patient as well, which is great. But I feel like we've been smart about how we've contracted this, and it's worked out really well for patients.
That's a really good point on how much it would cost to the family or to the patient, right? Because I think even thinking about deductibles, so would a deductible apply in most cases here, or would it not apply, or depends on the plan?
I think everything depends on the plan, but typically, you know, if you have a deductible for an overall plan, like most people when they have a plan, they have a $500 or $1,000 deductible if you pay that first. That would probably apply. But a hospital deductible would not apply to us because we're not a hospital, right? We're not doing that. So it's a little bit different that way. So it works out really well. And one thing I'll point out that's really nice is I always tell people, like, just call us even before you need us and find out like what your insurance is and what it will look like for you, because you should know this is available. And I'll say this for all your listeners. Look, we're true high acuity care. There aren't a lot of folks out there like us, but there are ones that are kind of a step down from us that could be helpful. And your listeners should go search for something called mobile urgent care. And they should go to Google mobile urgent care in their county. See what comes up and see who's out there. And those are folks that can probably do 60, 70% of what we can do. Maybe not to the level and everything, but I think it's a great start in your communities for you to be able to do that. So I would definitely take the time to go ahead and do it. So I always tell people to call us and see what, you know, their insurance and everything. What's nice about us is a patient will always know where they stand when they first call us. Whereas if you go to the hospital, you have no idea what that bill is going to be for like 2 months until it shows up, and there's nothing you can really do about it at that point, and it's always a surprise. The only time it's not been a surprise for me is my wife is actually a palliative care nurse for a local health system, and because if you go in the health system, it's the greatest insurance in the world. Like there's very little cost share, but that's the only time I haven't been blown away by the bill that I get, and it's because she works for a health system, and that's where we go.
Yeah, working for a major health system, we've had the same experience. And then the minute you leave that, you're like, whoa, how much does healthcare cost?
Well, my daughter went to school out of state.
Yeah.
My daughter went to school out of state, and that's not great, right? Because it's great if you're in state, but if you're out of state, it's not as, exactly. It's great in the system.
Yeah, I know. It does create a lot of blinders on, though, because you forget how much it actually costs. And then you leave the system or you go out of state or something, and you're like, whoa. Yeah. I'm putting my business hat on for a second because I'm thinking about how, like, I feel like hospitals would love this for not just the reason of like offloading capacity in the ED, right? Because of course there's all these penalties with you can't go on divergence, you can't go have too long wait periods, or there's all these things, right? So there's a whole lot of benefits on that end. But because you said that it doesn't count as a traditional hospitalization, I find that for patients, because I worked on our hospital readmission team when I was there, and I feel like the patients who are highest risk for readmission should be following up with a service like yours at home, because it would significantly decrease their risk of getting readmitted.
Absolutely. And I don't want to dork out with your listeners, so I won't get too, dork out too much.
Maybe we'll position this to the healthcare providers.
Yeah. So I don't want to dork out too much, but your hospital, especially for Medicare, is probably on the hook for your readmission for certain things. Yes. They have Medicare penalty admission penalties. So like we work with a lot of hospitals, and one of them right now is talking about when they have somebody come in with one of these Medicare penalty diagnoses, that when they get treated, they get sent home with a bracelet that says Care2U. If you have an exacerbation or need care, call Care2U. Because what's great is, maybe 10% of those people are going to need that care, but we're probably going to stop 80% of that 10% from readmitting, and their hospital penalties are going to be non-existent, right? Like they're going to do better than everybody else, and it's already starting to be proven out. So readmissions are a really big thing. A lot of these systems are starting to get into risk themselves. They love it when they're at risk. There's this new Medicare team model that they're in for like a 30-day period where all costs are bundled in, which could be interesting for you to think about. And there's also a new ACO model called LEAD that you may have a role in with what you're doing. So you could look into that one as well. So there's all kinds of really cool areas. And one thing that people don't realize is it depends on your insurance. Hospitals love commercial health insurance, which is what your typical 21-year-old worker to 60-year-old worker gets, right? They love that because there's profit in that. Medicare, they may make a couple bucks, but they likely will lose a couple dollars on admission. Medicaid, they lose like 10 to 15% on every admission. So if a hospital had a partner like us, where somebody went to the ED and they could offer hospital level care at home, that actually solves their loss problem very immediately, and then they can fill a bed with a more profitable admission. That's me dorking out, right? That they can do those things, right? So it's it's interesting. There's a whole business to this healthcare thing that people don't think about.
There is, and I think of course, like as someone who works in the systems, I know that healthcare in our country is atrocious, right? Like I know that our systems can be better, and that's why we do the work that we do. We try to make them better. I do think there's a benefit to you dorking out over that, because I think the general population does need some awareness around how hospital systems work, right? At the end of the day, it comes down to what insurance payers are willing to pay and if they can turn a profit so they can employ the people they employ to be able to take care of you. And that's really all it is. It's a business in the sense that the hospitals are dependent on external third-party payers to support you. And so I think it does help people understand that, and so that they're not mad at the hospitals, they're mad at the larger systems, right? And I think I always say that because I do find that in my line of work, I hear a lot of complaints about hospitals and care and all of that, right? And a lot of it comes down to people just not knowing how it works. So I really like that. I have a lot of questions, but my one question, earlier you brought up IV infusions or IV antibiotics or something that someone needs. Now, generally, that would probably be, I guess it would only be like 1 to 2 times a day. So you were saying someone would go in 1 to 2 times a day if they needed that?
Yep, exactly.
And if they needed something that was more than that, would you send them to a hospital then at that point?
No, we'd probably arrange some kind of infusion provider. I mean, we're really mindful to make sure that, when it comes to medication choices, there are a lot of medication choices that you can make once or twice a day. If they needed one that was 3 times a day, either one, we'd probably try to find a way to make it work to bridge that gap to a provider, another provider being able to come in and do that. But my goal is to keep people out of the hospital that don't need to be in the hospital. I just want to be clear in saying that, I think I love hospitals and I think they're great, but they're great for certain things. They don't have to be for everything. And that's the problem. We just default to hospitals for things. So,
No, I agree. I'd be interested in how you navigate this, because we get a lot of admissions for placement with older adults, right? So you'll get people who are like admitted for placement because the family decided they can no longer take care of this person, or something's happening and the patient lives alone and doesn't have support and needs to be placement. Now, for the listeners, placement could mean rehab or it could mean long-term care. We don't really know what they're coming in with.
Right.
But in a lot of cases, it's a transition into a nursing facility of some sort. And that takes up a hospital bed for a non-medical need. We have started programs in our emergency rooms to try and get them to transfer directly from the emergency room to a facility so that they don't have to get admitted, right? Because that's a whole nother level of cost and one less person who could receive medical care. Do you handle any of that stuff? How do you handle that stuff?
That's a really good question. I'll be honest and say I don't have a lot of insight into that one, but I'm going to take that away, and I want to ask my team and understand if we've had a lot of those situations that have arisen for us. I don't think that we have, but it's something that I need to ask more about because it has not come up very openly.
Yeah.
It has not come up for us. But when you have problems, there are opportunities for you to explore. I'll write that one down and I'll take a look at that.
Yeah, no, I was just curious because if that could also be handled or managed in the community, then that also helps decrease the burden on the hospitals as well.
Yeah, I can imagine, obviously, the medical part could probably be handled in the community, but you would probably need, if the problem is they don't have a safe environment, then you probably need to find an unskilled kind of home health. And when I say unskilled, that doesn't mean they don't have skills, but people say skilled and unskilled, skilled being nursing and unskilled being typically non-nursing. So I don't want people to think that, but you'd probably need somebody in the home for that to be safe. So that's where that would probably require some thought. But, if there are hospitals listening in my neck of the woods and it's a problem, let me know because we'll try and come up with a solution together.
Yeah, creative solutions, right?
That's how these things happen.
Yeah, absolutely. I know we talked about shedding light on the caregivers. Now, this is more of my bread and butter now, right? I talk and work with a lot of family caregivers. I do a lot of education and awareness for them, and a lot of work around decreasing the demands that we place on family caregivers. And so you brought up the fact that this is better for the family caregivers. And from your perspective, I want to understand what you have seen as a burden from a hospital standpoint, and then what you feel the burden, how that burden or those demands shift with this in-home service.
Yeah. So I want to be clear and say that I see a lot of positives in this from a caregiver perspective. I'm sure you could perceive there might be a couple of them that, now you've got a caregiver in the home that has somebody at home. And if they were looking for something called respite care, where they're just literally pushing somebody off somewhere, it's not going to be that. But typically the folks that we're keeping at home are folks that are capable of being at home. So I look at it as it's a huge shift for the caregiver to just have that peace of mind to know that their loved one is in the home with them. They're in their own bed. They're with their family and their pets. They don't have to now get somebody to watch the pets, somebody to watch the kids, whatever that may be, go to the hospital, do all those kind of things, spend all the hours and all the time there. It keeps you in your environment and it keeps things moving forward. So I just feel like the home, honestly, is a much better place to heal from my perspective. And once again, you're not around a lot of infection, it scares me. Every time I have to go to the ER with my mother, I worry, what am I'm the guy that still goes on the airplane with a mask on. I'm the one person on the plane just because I travel so much that I pick something up every time, it happens. So I want to stay away from those kind of high infection areas as much as I possibly can. So I think the burden shifts a little bit. I think it gets significantly better, but you do have somebody at home that is in a technical hospital at home, but it's not a high need kind of situation like that. If it was truly a high need situation, high intensity, they would be in the hospital typically. So I think it just gets a whole lot better for the caregiver to have that peace of mind to know they're home and then be able to continue on with their life. Because, I have, for HIPAA violations, I'll just say that I have a family member right now. This is not my mother, which I talked about before, but I have a family member who the husband is now in a skilled nursing facility. And it's like, it turns the world upside down for a while because now she's in there all the time with that person. everything revolves around that. It gets very, very complicated, right? And it's mentally, it's not a good place for a caregiver. That's mentally incredibly draining. And if this person were able to be at home, which they're not, I think that would just create a much better, safer routine for everyone. And I think that's the big thing. Keeping your routine, I think people underestimate how important routine is. I just went on vacation like 2 weeks ago, and as much as I had a great hiking trip and loved it, I craved coming home to my routine, getting up and working out, eating healthy, doing those things. It's so critical just for clarity, so.
Yeah,
I'll stop talking. I'm saying a lot of words here. I apologize.
No, that's okay. No, I can definitely agree with that. My husband and I just got back from 3 weeks and we were so excited to be like, okay, back to routine, right? And of course, as an OT, we talk about routines all the time and how important they are for people day to day. And I think you made a really good point. I also want to shed light on the external demands that are placed on a family caregiver when they are expected to show up to a hospital or emergency room or an urgent care, because now in places like New York City or Chicago, you have to drive through the traffic, or you're taking a train, but probably driving because your family member's sick, and then trying to find parking, and then trying to get inside and having to sit there and navigate all of that. That places a lot of other extra external demands that is not truly just medical in nature, right? And then, like you said, you have to figure out caregiving things at home if you have kids or pets, or if you are at work, if you work from home, you have to now step away, right? There's so many demands that get placed in these situations that could be mitigated with having access to someone who can just come over to your home and check out and figure out if you even need to go to the hospital.
You're right. And working from home for a caregiver. Like this in our world now, I work from home. I work remotely, right? I mean, it's fantastic for that. I could manage somebody in the other room that was on a hospital level care at home episode. I could definitely do it.
Yeah.
It would be a whole lot harder if I had to spend, 4, 6, 8 hours a day in the hospital. That would be very difficult to manage.
Yes, absolutely. Exactly. Well, Lon, I'm sure we could talk so much more, especially deep dives into the healthcare space. But for what we were talking about today, I think this was a really good conversation and gave people a lot to think about. If a family wanted to reach out to you directly, what's the best way to get a hold of you?
Yeah, I would say go to care2u.com. So once again, CARE number 2 letter U.com. You could submit a form right on there. Just ask for Lon and it'll come right to me. I'm also on social media. Probably the best way is LinkedIn, I would say. And my first name is Lon, last name is Hecht. So probably the best way to get me.
Awesome. Well, Lon, thank you so much for coming on and sharing this with us today.
Thank you so much for having me. It was a pleasure.
Absolutely. Thank you for listening to the Aging Together podcast. If today's conversation helped you, please follow the show, share it with a friend, or leave a quick rating or review. Your support keeps this podcast free, ad light, and growing. Until next time, let's keep learning and aging together. Take care.